who have signed up tonight certainly confirms it. A very exciting area today in the field of cornea and contact lenses, and that is the application of amniotic membrane lenses. These devices have improved the quality of life significantly for an increasing but still insufficient number of patients. We have someone very qualified to address this topic who in fact has fit hundreds of these devices. Back last year, she gave a 2-hour presentation at the Bronstein seminar, and she also was a co-author of a very good article in last year in Contact Lens Spectrum. I would like to say that she's a rising star, but she has far surpassed that status, and few optometrists, if any, in the United States are in more demand as a speaker as she is. She's currently a partner in a private practice with locations in both Arizona and California. She graduated with honors from the Southern California College of Optometry and then completed a cornea and contact lens residency at the University of Missouri, St. Louis. She's a fellow of the American Academy of Optometry. She's a fellow and currently vice president of the Scleral Lens Education Society. We're proud that she's an advisory board member of the GPLI. She's a former columnist for Review of Cornea and Contact Lenses and currently authors the GP Insights column for Contact Lens Spectrum. Speaking on the topic of amniotic membrane and specialty soft lens update, please welcome Dr. Stephanie Wu.
Thanks, Ed, for that awesome introduction, and thank you all for joining me tonight on this topic that is near and dear to my heart. I love amniotic membranes and specialty soft lenses, so thank you all for spending your evening with me. Here's just some financial disclosures. So first, I just want to start off with what is an amniotic membrane? Well, they are derived from placentas, and that's important, especially when we're talking to patients about what this product is, how we're using it, and how it can benefit them. The amniotic membrane, if you can see from this picture, is the innermost layer of the fetal membranes. It has an epithelial layer, a basement membrane layer, and then a stroma. So what does this amniotic membrane actually do for the developing baby? Well, it's the membrane that really closely covers the embryo, as you can see in this photo. And what it does is it actually fills with amniotic fluid, which causes it to expand, and that is what actually becomes the amniotic sac. The purpose of the amniotic sac is to provide a protective environment for the developing baby. So as the fetus develops, in case there's, let's say the mother gets hit on the stomach or something to that nature, it creates a very buoyant environment and absorbs a lot of shock waves as well. So what's the history of amniotic membrane use? When did people actually start saying, hey, yeah, I think that we should use this stuff, and start using it on wounds? Well, from the early 20th century, that's when some of the data has been shown in the current research, and that's when wound and reconstructive purposes really started out. And they have been proven effective at healing these wounds, but the mechanism of action is poorly understood. And this is found in many, many different citations. They don't really know why it works. They have some theories out there that I'm going to get into, but they don't know 100% why this is effective. There are some growth factors that are in amniotic tissue, and the growth factors are thought to assist in some of the healing and provide regenerative properties. Amniotic membranes are also rich in collagen. You know, as eye doctors, we're very familiar with collagen and how it can help patients. So this tissue is really, really rich in collagen and various growth factors, and that is thought to also assist with the healing process. Amniotic membranes can also improve wound closure, so it can actually help a wound that's open heal faster. And something else really important for me as an optometrist is that it helps to reduce scar tissue formation. Something else unique about amniotic membranes is that they lack immunologic markers. What that means is it's very, very difficult for the patient to reject the actual material because their stem cells, they really don't have an orientation yet. So when you put it on a patient in any regard, there's very little chance that the patient will have a rejection or some sort of allergic reaction. The amniotic tissue also has antibacterial properties, antiviral properties, so it can actually kill some of these bacteria and viruses, funguses, things like that. Another benefit is the ability to help with pain. So if you have a patient that's in a lot of pain, a stem cell or amniotic tissue may help to reduce the amount of pain or help the pain go away faster. So some of the historical uses of amniotic membranes when they first started to be introduced in the medical world is for the treatment of acute chemical burns. That's what we're looking at on the side over there. Is they started using these for burn victims where their skin was basically just melted off and they basically had this giant open wound. So they use this amniotic tissue to kind of use as a covering and not only to help protect the skin and help it regenerate faster, but also to help with pain, inflammation, and improve the healing time. Also, when they're trying to reconstruct different cavities within the body, they will actually use this tissue during those procedures as well. Something else important is that it actually helps to prevent tissue adhesion. So let's say a surgeon is working on structure in the abdomen or pelvic area. So let's say they were trying to do a surgery on the uterus, but they didn't want the areas that were operated on to form tissue adhesions to the bladder or any other structure that's near that organ. If you put amniotic tissue in between some of these areas, then you can prevent that tissue from scarring, forming these adhesions with other organs, and it can really help with surgical procedures. And I'm sorry, I always give this lecture right before dinner or right after dinner, so bear with me for the next few slides, and hopefully nobody gets sick. So what we're looking at, these are courtesy of a podiatrist, and what we're looking at here is a patient that has a diabetic foot ulcer, which has become a huge use in the amniotic membrane world. So you can see on the left foot, that actually has been an open wound like that neurotrophic kind of ulcer here for 5 years. So what they did was, you can see that photo on the left is kind of where it started out. You can see that the tissue surrounding that ulcer is really hyperkeratotic, definitely no blood supply. It looks really, really stiff. It just does not look healthy at all. So they used an amniotic membrane, kind of pushed some of that tissue in and formed a little semi-seal with some tape. And you can see that just after a couple weeks on that upper right-hand photo, that hyperkeratinized tissue is a lot better. It's getting a little bit more blood supply, more pink. And then the bottom photo is 4 weeks after the application of the amniotic membrane. And you can see that that wound is actually starting to close. That hole is actually starting to get smaller, and the tissue around it is becoming pink. It has vascularization. It's more pliable than the photo at the very top. This is a photo of the same foot 7.5 weeks later, so you can see that that ulcer is completely closed now. And then at 10.5 weeks, it's basically fully healed. So it's just really interesting that this foot ulcer that had remained like this for 5 years was completely healed, or almost completely healed, within 3 months. So it just really shows the power of amniotic membranes and how fast they can help things, and they can provide a treatment option when other treatments fail. So amniotic membranes, they do come from placentas, and this is from mothers that are undergoing a C-section. So these are uh, mothers that they already have a planned C-section. It's not one of the emergency type situations, and it's with facilities and clinics where the obstetrician has signed up with this company to donate the tissue. So they ask the mother, you have to have a C-section. Would you like to donate your placenta to science or whatever? And they say yes. And it is very heavily screened for communicable diseases such as syphilis, hepatitis, HIV, things of that nature. So what happens is the mother is routinely screened via blood tests to check for all of these diseases before she even delivers the baby. Then when the baby's delivered, the placenta is immediately tested. It's transported to the tissue processing facility where it's checked again for these diseases, and then the mother is actually followed for, I think, 12 weeks after the tissue's donated to make sure that nothing has come up after that, because if it does, they have to recall that batch of tissue. So we kind of know now a little bit about the history of amniotic membranes for regular medicine, but when did somebody say, well, I think we should try it on the eyeball now? So from the research and literature that I've done, I've found that in 1940 there was someone by the name of de Roth who actually used it for a chemical burn of the ocular surface. But it wasn't until 1992 that the amniotic membrane reemerged as an important modality of treatment for ocular use. To date, there are over 700 peer-reviewed publications for the ocular use of amniotic membranes. So this is not just amniotic membranes, this is solely ocular. And you can see from this graph, 1946, there's a couple reports, and then it kind of dies off. And then in the late 90s, early 2000s, it's really starting to ramp up again. And I would say even past 2008, that's really kind of exponentially increased. So you can really see that there are lots of peer-reviewed publications highlighting the use of amniotic membranes with the eye. Something else important is that amniotic membranes help with inflammation. As we know, the first thing that happens when your body is injured is inflammation. But uncontrolled inflammation can lead to a lot of pain. Think of patients with cataract surgery. If they have extra inflammation, they're going to be in a lot of discomfort. Uncontrolled inflammation can also lead to irritation. They can feel like something's in their eye. It constantly feels like a foreign body sensation. Can also lead to delayed healing. So the longer it takes for any part of the body that has excess inflammation to heal, that just creates more damage down the road. So there's more complications like scarring, hazing, things like that, which is really important to consider when we're talking about the eye. So it's really important to control the inflammation as much as we can to not only help with the pain and the physical well-being of that patient, but also to help heal that eye faster and also minimize the risk of these scars or corneal haze, because that can really, really affect the patient's vision. So how does it work? Like I said in the beginning, they really don't know. It's really a poorly understood mechanism of action. They think maybe the heavy chain hyaluronic acids along with the growth factors that's in amniotic tissue might be a key component. And what that can do is actually neutralize that neutrophil activity, which in essence kind of downgrades that inflammation pathway, kind of stops it in its tracks, or at least calms it down and gets it under control very, very quickly and effectively. Because we are stopping that inflammation in its tracks or slowing it down significantly, that will decrease the likelihood of scarring potential. It also, inhibits these inflammatory cells, so it suppresses T cells and giant cell formation, As we know with the eye T cells, and this has become a really hot topic recently, especially with dry eye and such. So if we can calm down those T cells and kind of inhibit them from acting up, we can also help with that inflammation. PTX3 is another component which can reinforce that heavy chain hyaluronic acid, which also can promote healing faster. Essentially, amniotic membranes provide an anti-inflammatory environment, or at least calms down the inflammation and gets it under control very, very quickly. It promotes the limbal stem cells to expand and start the healing process, promotes those cells to migrate quicker, so the healing is faster, expedites the recovery time. So instead of a patient that would have taken X amount of days, it can cut it in half, sometimes extremely fast, which I'll show some case reports here in a moment. And it also can suppress pain. So patients that have some sort of anterior cornea problem and they're in a lot of pain, it can help reduce that pain. So there's basically two options out there. There's dry or dehydrated, and then there's also wet. The dry amniotic tissue is dehydrated in a way that preserves those key elements that are associated with healing. The tissue is packaged and stored at room temperature and has a 5-year shelf life. This is an example of what it might look like. It's really, really thin, almost looks like rice paper, and these can come in different sizes, so depending on what you're using it for. So some surgeons use it for pterygium surgery, and they need like a square or a rectangle shaped piece. With optometry, we use more of the circular pieces because we're putting them in a contact lens. And they kind of look like this. It's real thin, almost looks like rice paper, but you can get them in different diameters, 9 millimeters, 10, 11, 14, whatever you need, there it is available. Wet amniotic membranes are made by clipping a piece of amniotic membrane in between two rings that are made out of a clear flexible material. These are also cryopreserved, which is important because that might retain some of the more natural components within amniotic tissue. They are stored in a glycerol media, so when you get this tissue, it's kind of in a liquid that helps to prevent it from freezing. If you are going to store it in a regular refrigerator, that should be stored only for about 3 months, so you'll have to use it fairly quickly. Here is a picture of the wet amniotic tissue. So you can see that in the center, it's still really transparent, and it's made with this polycarbonate ring. It's about 16.5 millimeters in diameter, so it is fairly large. And then if you put this in the freezer for storage, that will actually last for 1 year. That will have a shelf life a little bit longer than just storing it in the refrigerator. And then also, if you've got one of the industry strength freezers that they will give you if you purchase a certain amount of this tissue, that can actually be stored for up to 2 years. So the colder you get, the longer the shelf life. So there are some other differences between the dry and wet tissue. Dry or dehydrated amniotic membranes are usually cheaper for the practitioner. So that's important, especially if you don't know how much you're going to be reimbursed or if you don't have a prior authorization for this. So that's definitely something to consider. It's really easy to store, so you can just pop it on a shelf. It does not need to be refrigerated. It does not need to stay cold, so you can kind of just keep it on the shelf. The shelf life is really long, so you can have it up to 5 years. So if you have one and you're not sure when you're going to need it, you have 5 years to use it. And I guarantee within 5 years, all of us are going to have at least one patient that can benefit from this. I think it's more comfortable for the patient. It doesn't really feel like anything. It has a slight sensation, but the patient doesn't really notice it compared to the ring. With the wet or the cryopreserved membrane, because it's more in that natural state of the amnion, it may be retaining more of the innate characteristics, which can result in potentially better outcomes. It is cryopreserved, so those qualities of the amniotic tissue, that fresh tissue, is really maintained until you open the package. So that's really cool. The cryopreserved tissue is the only tissue that's actually cleared for wound healing by the FDA. So with dry, just the opposite of the wet tissue, it may not retain all of those characteristics of the natural amnion, which kind of makes sense, right? Because we've got, this tissue that's been dehydrated, and each company that has dehydrated product does it a little bit differently. And they try to do it in a way that maintains some of those innate characteristics, but it may not work exactly the same as the wet or cryopreserved product. Some of the amniotic tissues, when they are checking these heavy chain hyaluronic acid and pentraxin 3, which are essential for wound healing, it's thought, it only contains trace amounts. So you might not be getting the full benefit compared to using the cryopreserved treatment. Wet tissue, it does have a shorter shelf life, so it could be a more of an investment for you. And if you're not sure if you're going to be using it within 3 months, definitely don't store it in the fridge. Even if within a year, if you're like, I just don't know if I'm going to use it, the cryopreserved may not be the best option. It generally is more costly to the practitioner, and that's because you have to think about the technology that goes into that. It's all cryopreserved. The way that they manufacture and treat and handle the product is different than the dehydrated, so those costs are extended onto the practitioner. You have to store it in a refrigerator or freezer. And for me, something that happened actually a few years back is I live in a really, really hot city. And in the middle of the summer, we have these monsoons. And one day it took out the whole power in the city for multiple hours. And so I thought, oh my gosh, all of my cryopreserved ones are dead. So I had to call the company and find out if they really were dead and all this stuff. So if you want to have peace of mind, and if something like this might happen to you, you might want to consider the dehydrated. It might be more uncomfortable for the cryopreserved tissue, and it's largely due to that plastic ring. It's very large, 16.5 millimeters in diameter, made out of that polycarbonate material. So the patients will feel it more compared to the dehydrated product. But sometimes if it's a totally necessary thing, or I feel like the patient really, really needs this, I will just tell them, it's like a cast. Yes, if you break your arm, it doesn't feel good to have it in a cast, and it's annoying and it's uncomfortable and you might have trouble sleeping, but it's healing your arm. So you've got to look at it the same way with the eye. Yes, it's uncomfortable, but it is healing your eye. So, the benefits greatly outweigh the pros greatly outweigh the cons in my opinion for some of these really extreme cases. Some of the risks, well, of course, you're always going to have that risk of transferable diseases like HIV and hepatitis, syphilis, things like that. But they are very, very highly regulated, and the quality control from the FDA is very, very good. To date, there have been no known cases that have reported any of these transferable diseases, but of course that will always be a risk. And then I found this article about some corneal calcifications that happened after amniotic membrane was used on the ocular surface, and it was of a few patients. But at the end, they did say they weren't sure if it was from the amniotic membrane or if it was from some of the eye drops, because a lot of the eye drops they were using had different metallic components and preservatives, so that they weren't 100% certain if it was an amniotic membrane. Personally, I've never seen this, but I just found this, so I thought it would be interesting to at least bring it up to you. So I always get the question, which one's better, wet or dry? Of course, there's no right or wrong answer. It really depends on you as the practitioner. It depends on the patient and the condition that's being treated. I have used both products. Like Dr. Bennett said, I've fit hundreds of these tissues, all from different companies, all from different for different conditions on different patients, and I've had success with both products. And I'll share some of the case reports with you, kind of highlighting some of these cool uses. So essentially, these amniotic membranes can offer quicker healing time, which is great, less pain for patients, less scarring, which is huge for the cornea, and less inflammation. So how can we use it in optometry? Well, we can use it on our Stevens-Johnson patients if you have any of those in your clinic. Shield ulcers, corneal abrasions. Here's a patient I had who thought that she had a contact lens in, and she kept trying to get the contact lens out, and then she came to the clinic and said, I can't get this contact lens out, and it was because there was nothing there. So we used an amniotic membrane on her, very, very large abrasion. Corneal ulcers, this has really become actually my standard of care. I have had some amazing results with corneal ulcers. Patients that would have scarred down or have had very terrible scars from ulcers, and they either have no scar or the scar is so minimal, or it's really become a gold standard of care for my patients. I always want to put an amniotic membrane on my ulcer patients because it helps to limit their scar tissue formation or eliminate it completely, which I think is completely amazing. Corneal burns or chemical burns. Patients with filamentary keratitis, these patients are really uncomfortable. So what you can do is peel off those little filaments, or you can debride the cornea completely and then put on a stem cell and see if it helps to kind of just kind of make that basement membrane a little bit stronger. So I have great success. Some patients don't respond at all to it, but there are some patients that it has been life-changing for them with filamentary keratitis. So definitely think about this for some of your patients. Dry eye and exposure keratopathy, we see this every day as optometrists. So I think that it's an amazing use for patients that have dry eye, punctate keratitis, things of that nature. Recurrent corneal erosions, I've had some patients that have had this as well. And think about these patients, they get scared at night that when they wake up in the morning, they're not sure if their eyelid is going to rip off their cornea. So these are some other patients that it's been life-changing for some people. Again, some patients don't respond at all. They get another one, a week later. Other people, I have one patient where we did it about 4 years ago, and she has not had a recurrence since, and she was having them about every 3 months. So that is truly amazing. Salzmann's nodular degeneration, I don't see this that often, but it can definitely be an option if you desire. And then our chemical and thermal burns for corneas and post-infectious keratitis. So think about it for optometrists. How many patients are you referring out to like a corneal specialist that you could potentially manage in your own office and keep them in-house? How many bandaged lens patients, patients that have abrasions or keratitis or, just some SPK that you are just putting in a bandage lens that might actually benefit more from an amniotic membrane? Maybe it will heal it faster. Maybe the risk of scar tissue, if they've got a large abrasion, will be much less. The healing time's faster, less pain. And think about your dry eye patients. There might be some dry eye patients out there because it helps with the inflammation. And as we're learning, dry eye has a huge part to do with the uncontrolled inflammation on the eye. And getting the inflammation under control is one of the most important things for a dry eye patient. So if this can help get some of that inflammation under control, might as well try it. So, think about your bandage lens patients. A lot of patients present to our office with a variety of these superficial corneal problems that we can really keep in-house and manage on our own. So this is a cool study that was done in, it was presented in Review of Ophthalmology in September of 2014. We have to remember this was sponsored by BioTissue, which are the creators of the Procura, which is that cryopreserved amniotic tissue. And what they did was they had 10 patients, and they wanted to compare the Procara compared with a bandage contact lens after patients had superficial keratectomy on both eyes. So these patients had superficial keratectomies for a variety of reasons, and one eye got the Procara, and then the other eye got a bandage contact lens. So this is what they found. You can see on this graph, this is showing us how many eyes got 100% re-epithelialization. Well, on day 3, there was actually one patient or one eye that had the Procara treatment that had 100% re-epithelialization, which is amazing. On day 5, you can see 7 patients, and then day 7, we've got 8 patients that were 100%. Compared to the bandage lens treatment, where day 5 there were only 2 patients that had 100%, and then on day 7, 5. So you can see that the Procara is really speeding up the treatment and helping that cornea heal faster. Also, you can see the number of eyes that were completely clear of corneal haze. Well, of course, on day 1, that's going to be nobody because they just had the procedure. But on day 7, the Procara treatment helped 9 patients completely clear of corneal haze, and you can't see any of the bandage contact lens treatments. So I think this is actually very reflective of what I see in clinic. So even though this was a sponsored study, I definitely see this in my own practice, and so I thought that I would share this with you guys because I definitely see corneas healing faster and with less haze. So how do you get paid? The proper code for this is 65778. So make sure you're using that code when you're billing. Used to have a 10-day global period, so you couldn't do it. You had to wait 10 days to put another tissue on. But as of March 2016, there's a 0-day global period. That means if you put on an amniotic membrane, the patient comes in the next day and they need another one, you can bill for it again. How much does it cost? Well, to you as a practitioner, it can range from $400 to $1,000 in that kind of general area. That depends on the device. Remember, we said the dehydrated tissue was a little bit less expensive, and then the cryopreserved is more expensive. And then usually if you buy in bulk, you will get more of a discount, like most items. This is from 2015, but in Arizona, the Medicare reimbursement was around $1,400. I think now it's more around $1,300, but it still reimburses at a pretty high level compared to other services and procedures that we offer in the practice. There is something I should mention. There's a Medicare carrier in another state, not Arizona. I'm not even sure exactly what state it is, but they only recognize that cryopreserved amniotic membrane for that code of 65778. So if you use a dehydrated tissue, you cannot use that code. I'm not sure what state it is, but as we know with Medicare, it's like once one state adopts this thing, it starts trickling down, and soon everybody will have to be adopting that same philosophy. So that is very important to let you guys know about. At the moment, at least in Arizona and California, that's not the case, but it could be in states that you are practicing. So just a few case reports I will go through really quickly because I know we got to get through more stuff, but I love these before and after photos. I had a patient, a 54-year-old female, that she complained that she had a white spot on the left eye. She found it 2 days ago. Her eyes watery, red. She currently wears AccuView 2s and sleeps in the lenses occasionally. So you can see here, this is what I saw with the slit lamp. It is right smack dab in the middle of her cornea, middle of her pupil. So in this case, I want to try to help heal this cornea as quickly as possible. We know that there's potential for vision loss because of the location and the size. So she had a large central corneal ulcer or abrasion without a hypopyon. So we started her on fortified tobramycin every hour and Vigamox every hour. And I put the ambiodisc in right away, and then I followed her up in 24 hours. And a lot of practitioners ask me, well, wouldn't you do the eye drops first, get that ulcer to start healing, and then put the ambiodisc on later, or the whatever amniotic tissue you're using? I guess for me, I feel like I put it in right away because I'm trying to decrease not only the pain, expedite the healing, but I'm trying to decrease that scar tissue right away. So I try to put it on as quickly as I can. The results I've had have been very good. So in some cases, you might be more comfortable keeping them on the antibiotics for a while and then putting the amniotic membrane on. But I personally put it on as soon as I can. One day follow-up, the ulcer had decreased in size and she had less microcystic edema. I continued the eye drops exactly the same. And then we followed up with her about every 24 hours for the first 4 days, and then every 48 hours for about a week. Every single day we saw her, there was an improvement. You can see after 2 weeks that scar has, or that ulcer has significantly improved in size, shape, and it just looks a lot less angry and irritated. So starting from, this big ulcer or abrasion in the center of her eye, very large, she's got that edema surrounding that ulcer, and she's just so much better in this case. So you can see what a drastic effect that amniotic tissue had. Another case report, have a patient with severe dry left eye who's had RK surgery, cataract surgery, dry eye, and of course you can see that this female is managed with lots of different things for dry eye. And this is what she presented like. You can kind of see the RK cuts behind there, and she's got some significant punctate keratitis. So she's got some dense SPK due to dry eye. So we continued everything that she was doing, and then I just put an ambiodisc on her, and she was doing much better after a week using everything as recommended. And you can see all of those little areas are healed. So in this case, I do want to mention that she's got that underlying condition that her eye's really dry. So it's not like this totally cured everything, but every once in a while she'll pop in, we'll put another amniotic membrane on, and she's pretty good for a while. She recently was fit into scleral lenses, and she wears them every once in a while to help some of the dry eye. So, it's not a perfect thing. It didn't heal her eye 100%, so she's never going to have to do anything again, but it just kind of calms down that inflammation, healed those little areas on the cornea, and really kind of helps keep her condition under control. Just some other quick, really cool before and after photos before we take some questions. This is a patient that had herpes simplex, and you can see the top photo is before we put a Procara on. 5 days later, it is significantly improved, and 2 months later, you can see her cornea is just crystal clear, absolutely no scar tissue, which is fantastic. I've got lots of patients that have had herpes and have had really, really bad scars, and it has affected their vision permanently. Whereas this patient, you can see she turned out really, really well, and her vision wasn't affected at all. Here's another herpes patient. She's recurrent a lot, but you can see after 1 week of a Procara, that epithelial surface and that kind of just anterior surface of her cornea just looks a lot smoother. I love this photo, and I just think this is amazing. A patient with the top photo has got a nasty corneal ulcer. You can see the edema surrounding it. And after using a Procara, there's absolutely no scar tissue or corneal haze. It's just a beautiful, clear cornea. I mean, this is absolutely amazing. Think about the corneal ulcer patients that you have who have scarred down and have permanently affected their vision. So that's why in my practice now, anybody that's got a corneal ulcer, especially if it's central like that, my gold standard treatment is an amniotic membrane if the patient agrees to doing that. If it was my own family member, 100%, I would be putting an amniotic membrane on, because I've got plenty of patients where we've just used drops, used antibiotics until it re-epithelialized, and then used steroids steroids, and then but they still have this scar, and it permanently affects their vision. Whereas this patient, they just healed so nicely with absolutely no scar tissue. And I just think that the technology behind amniotic membranes is just so amazing. Just a couple other photos on the left-hand side and right-hand side. There's another dehydrated product called BioD that we use for patients that have got really nasty corneas, and you can see how much clearer the patient's corneas look. They don't always work. I'm not going to tell you that this is the best thing since sliced bread, because I mean, I feel like it is because of how much it has helped my patients, but it's not the end all be all for everything. Similar to one of the first case reports, a patient that's got some SPK, you can see after a week, wow, she looks great after that amniotic membrane. But a month later, she does have some SPK coming back. And that's because she's got dry eye, and we're managing that condition constantly. So it's not that it cured it completely, but it can provide some relief and kind of expedite that healing process. Same thing with this patient, chronic dry eye. You can see how bad, that front surface is. After a week, it looks much better after the amniotic membrane, but after a month, starting to get that SPK again. So it doesn't work 100% of the time, but it is a truly miraculous thing for a lot of patients. So, I just want to put it out there that these amniotic membranes have excellent anti-inflammatory properties, and we're really actively healing the surface. Instead of allowing these corneas to passively heal, we are taking action and putting these amniotic membranes on, which is expediting the healing process, and also can help reduce scar tissue formation and corneal haze. So in my opinion, they may not work for everybody, but if the patient has nothing to lose and the benefits greatly outweigh the risks, why not try it? So this is such an amazing tool that we have in our toolboxes for patients that have these anterior corneal problems.
Okay, very good, Stephanie. That's about as good an overview, and I know you were trying to cover as much as you could in a limited amount of time. I'm sitting here thinking, of course, I'm wondering if another potential application for amniotic membrane lenses would be in the unlikely event that your patient would have, for example, 27 lenses lodged underneath their upper lid, but we'll let that one go. And reminder to everybody who's on tonight, because I know this is an interesting topic and we have lots of questions, and keep in mind this will be archived. It'll be available within a couple of days if you want to go back and look at the information, and I think some of you definitely will be. Another call out to our advisory board members on tonight, besides Dr. Wu, are Doctors Mike Lipson, Bob Maynard, and Jeff Sonsino. And the first question is from Jeff. And Stephanie, what you said about no rejection issues is supported by the ophthalmological literature. I've had a complication where the patient's eye became completely opaque one day after amniotic membrane application. Any ideas about this? Was it corneal edema due to the bandage lens?
So Jeff, that's a really good question, because I actually had the same exact thing happen to me about 2 weeks ago. We put it on a patient that had just kind of a classic dry eye, and she came in the next day and I thought she had endophthalmitis. And so I was freaking out and calling the company and sending her to cornea and all these things. And it ended up being just like a very, very bad inflammatory reaction. So I don't know if it had to do with the way the tissue was processed. I had a couple other patients that had kind of weird reactions as well. So I actually sent the entire batch of tissue with that serial lot number back to the company and exchange it out for some other tissue. And they're running some tests on it right now. So I don't know if it was, maybe from the bandage lens, maybe just the cornea didn't get a ton of oxygen or something with that amniotic tissue in between, or if it's maybe the way that it's processed, because some of them are chemically processed. Some use gas to process, so maybe the patient had some sort of reaction to that. But Jeff, I'm totally with you. I just had a patient that had that exact experience, but I'll keep you posted on what I end up finding out from them. Good question.
Yeah, and I won't be able to get through all of them, Stephanie, but we'll take as many as we can. Mike Lipson asked, what's the biggest advantage of, in your mind, of amniotic membranes versus bandage contact lenses?
For me, I would say it is the active healing and reduction in scar tissue potential. Like I said, now my corneal ulcer patients, they all get an amniotic membrane if their insurance allows for it, or if they want to pay out of pocket for that. Just because I have so many case reports and before and after photos that are just mind blowing, just showing how amazing that this tissue can help the eye heal. So I would say, yeah, for me, it is just, it helps the eye heal faster and it helps to reduce the risk of scarring. Or if they do scar down, it's going to be much less than if you didn't use an amniotic membrane at all.
Okay, very good. Bob Mader wants to know, as a fellow Arizonian, why so many herpes in the practice? Is it the population that you see, or any specific reason?
Bob, I have no idea, and I guess it must not be in the water since we're both in Arizona. But for some reason, we've got a lot of pathology out here, and maybe it's because we live in a rural area and there are no ophthalmologists at two of my practices, so we just get everything that walks in the door, so they don't have any other option to see anybody. But I don't know why we have a lot of herpes out here. I guess I don't know.
Well, that's a good answer, actually. Have We had the question: have you ever noted significant diffuse SBK with the amniotic membrane or after use of it?
Yes. So there are some cases where I use it for SPK and then like I'll take it off a few days later and then the SPK is actually worse. So it's bizarre because you think, oh, gee, well, if I would have just used a bandage lens, it probably would have been better. And this is like a rare case that this happens to, but I'm not sure if it's the tissue because it's not a concave, the tissue's real flat. So I think a lot of that has to do with some problems is that it kind of forms like a little wrinkle, when you're placing down that tissue on the front of the eye. And then sometimes it can move around if it's not perfectly centered. Sometimes it can move underneath the bandage lens. And, some patients, they just don't respond well to it for whatever reason.
Yeah. And then Teresa Fan asks, is there a limit on how many times you can code for amniotic membranes per patient?
Well, so there used to be that 10-day global period, and now it is 0 day. So that means, if you have a patient, you can only use it once per day. So if you have a patient that needs it bilaterally, you're only going to get paid for one. But theoretically, if they came in the next day, you could bill for it again. And I have had a patient that had this very, very, very severe ulcer, and we were managing her, and the amniotic membrane kept dissolving because her ulcer was so big, and so it was eating up all of the tissue so quickly that we had to do like 4 of them within like a 2 week period, and they did pay for all of them. So I wouldn't like do it on every patient because that would probably be like a high flag for auditing, but technically there is a 0 day global period, so you can bill for it, or you can put one on every day if you needed to.
Well, you have to feel special, Stephanie. I've never seen this many questions except when we do coding and billing, which of course is another area you can handle as well. Marion asked, when would you consider, or when would you consider a scleral lens after you've used an amniotic membrane in a severe dry eye, like in a Stevens-Johnson or something?
Yeah, so I would say that I like to start with amniotic membranes because I think that it can kind of stop that inflammation right off the bat. So at least we can kind of get the eye under control as much as possible. But because these patients, like Stevens-Johnson patients or patients that have graft versus host disease, I mean, these people, it's not going to cure them. I mean, it might help them be more comfortable and it might help eliminate some of the SPK and stuff that's on the front surface of their cornea. But I would fit them in a scleral lens probably very quickly afterwards because the effects of the stem cell or the amniotic tissue is not going to last for that long. So I would say within a week, I would probably fit them in a scleral lens if you're managing them for dry eye.
Very good. There's a couple questions pertaining to ever fit an amniotic membrane post corneal graft, and if you do, does it have any effect in terms of potentially any negative effect on a PK cornea that might already be inflamed?
Yeah, so I actually have a lot of patients that have transplants that the surgeon uses this, or we put it on for the surgeon, that have had awesome results. We did have one that it seemed like it made it worse, and I think that you have to use caution because the eye is so fragile and delicate at that state that you have to think of the amount of oxygen they're getting, the risk of eye infection, the amount of inflammation that's already going on. But there are some surgeons that they always put an amniotic membrane on after every single cornea transplant they do. So there are some surgeons in the boat of every transplant's getting a membrane because it's going to help heal it faster and help the epithelialization occur quicker. And so I think that in transplant patients, of course, take caution and work with your surgeon carefully. But if you notice somebody that's got a lot of epithelial defects, they're in a lot of pain, it seems like their healing time is not, the best, I would certainly use that as an option, or at least talk to the surgeon about that.
Okay, very good. And knowing we have lots of questions, this will be the last one, Stephanie, so we'll allow you to complete your presentation. But uh, Manny Conde was asking, did you treat the herpes concomitant with drops or only just use the amniotic tissue?
Oh, good question. So yes, I always keep the eye drop regimen exactly the same as I would if I didn't use amniotic membrane. So in that case, she was using the Procara, and then she was using Veroptic, 5 times a day, 9 times a day, whatever we had her on, and it was acting as almost like a drug delivery device. So that's another benefit I forgot to mention on amniotic membranes, is that it can actually serve as a drug delivery device, which is awesome for these patients that need medicine. So same thing with an ulcer patient. I put the amniotic membrane on, but then I also will keep the eye drop regimen exactly the same. So if they're doing drops every hour, I'm going to keep on that regimen. So just basically keep your eye drop regimen the same is what my advice would be.
All right, very good. Stephanie, you can proceed and finish up.
All right. So thanks, Ed. Sorry, I was trying to do this within like 30 minutes, but I knew that I was not going to. I didn't realize it would take up almost the whole hour. So I'll just kind of speed through our custom lenses. So custom soft lenses are great because a lot of the larger contact lens companies actually discontinued their wider range of parameters, and that includes their extended sphere and cylinder powers. So that left this really big need for soft custom lenses, and this can actually offer us as practitioners a really cool opportunity so we can manage patients that need astigmatic correction or multifocal correction in a really precise way. So specialty labs, they produce these custom lenses, and the parameter range is amazing. I mean, some of these go out to -50, +50. I mean, geez, how much power can you get in some of these contacts? But, -20, +20, with up to 8 diopters of cylinder, which is amazing for a soft lens. And, Dr. Doug Benoit actually stated that the smaller labs have actually increased what we can do as practitioners. So more patients are actually able to stay in toric lenses. So good patients that you should consider for custom soft lenses would be patients that have a lot of astigmatism, patients that are unhappy with their current lenses. Maybe they've got lens rotation, or the fit's not very good because they have an HVID that falls in or outside, outside of those parameters of what's out there. And then patients that they want to try gas permeable lenses, but they're concerned about the comfort, or they're not willing to try them. Some of my favorite uses of soft custom lenses is actually astigmatic presbyopes, because think about how many soft lens options do we have for presbyopes that have astigmatism. There's not many out there, just standard lenses. So GP multifocals, scleral multifocals, hybrid multifocals are amazing, but sometimes there's patients that they want to stay in a soft lens and a custom lens, and we can do that for them. So these labs have really helped us get our patients into some amazing products. So some pros and cons of these types of lenses. It's the custom lenses can provide great vision with a great fit, and you really usually don't need to build up any wearing time compared to like gas permeable lenses. The lenses are usually quite stable because it's usually the base curve is usually fit to some sort of nomogram that the lab has. It really fits on the eye much better than just a standard contact lens. You can correct a large amount of astigmatism and multifocal correction. And it just gives your patients that would be a good candidate for a gas permeable lens, just gives them another option if they want to stay in a soft contact lens. Some of the cons, they might be more expensive compared to just your standard off-the-shelf contact lens that you have in your fitting sets. The vision might not be as good as a GP lens, so I always describe that to the patient and explain it to them right off the bat. Usually custom soft lenses, it's not going to be a daily replacement. This is something that, because they're expensive and have to be custom made, they usually are replaced on a quarterly, semi-annual, or annual basis. And then you kind of have to consider the cost of it, the lens. If something happens to it, if they lose it or damage it in any way, they're going to have to pay all over again for another lens. So most manufacturers use some sort of fitting nomogram to design the lens. Here's one where you can see if you've got a patient that's got a normal size cornea, then you would just use a 14.5 diameter. And then if the different diameters desired, you just either add or subtract to the HVID. And then you just basically use the average K. So if you look on the left-hand side, if you had an average K of 50, and you wanted to use a 14.5 diameter, you just kind of use that and say, oh, okay, so the lens diameter, or the base curve would be 8.0. Here's another one where if you use the flat K, basically that goes through whatever diameter you're going to use. So in this case, it would be 14.6. And then whatever material you want to select. So let's just say we want to use a 59%. And then that will give you what base curve. So in this case, it's 8.0. So ordering custom lenses is really easy. Most manufacturers only require Ks and refraction. So this is stuff that we already have on all of our patients that are coming in for their annual exam. If you do have a way to measure HVID, that can actually help provide an even more accurate lens. And something that I always like to point out is that about 26% of our patients actually fall out of the normal range of iris diameter. And this could be a large reason that contact lens patients drop out. So, 26%, that's 1 out of 4 of your contact lens patients. So, I mean, if you see 4 contact lens patients a day, 1 out of those 4 might have an HVID that actually falls outside of the normal range. And that could lead to their vision not being good, lens fluctuation, lens fit issues, things like that, and that they might drop out of contacts completely. Ordering lenses through your lab, the labs are so amazing. You just basically give them the data and they will calculate a lens for you and ship it. You can call them. I do all my ordering through email, and a lot of companies even have online tools where you can actually put in the material you want, the different K readings and the power, and then it basically just calculates a lens for you. Same thing, another company uses the same kind of nomogram where they're just kind of putting in the information and then it spits out a lens. Something else that's great is, custom lenses used to take a long time to be shipped and produced. It used to take a very, very long time to even manufacture these lenses, so weeks. But now, I mean, I'm getting these things within days, sometimes within 3 days if I need something really fast. So it's amazing, within a week you can have a lens in your hand. Other benefits, custom lenses, you can only get those through your office. It's not something they can get through a big box company or, 1-800 whatever. And so you can keep patients and they know you're on the cutting edge of technology. So of course, there's also irregular corneal soft contact lenses. So, the first part's talking about just your regular patients, but patients that actually have keratoconus, maybe they had a corneal transplant, maybe they've got a super high amount of astigmatism. So there are lenses out there that actually can correct for these conditions if you don't want to go to a gas permeable lens or the patient does not want to, or maybe you just want to try a soft custom lens. So there are some patients, and I have a handful of them, that they just are not willing to try a scleral lens. They don't like the fact that you have to put it in a certain way, that it's so large, you have to fill it with solution, you have to take care of it differently than a soft lens. So there are some patients that they just refuse to use scleral lenses, or they just can't. I just wanted to go through just a quick case report. Patient of 15 years old, so he's young, and he had unilateral keratoconus, good vision in the right eye, poor on the left, and you could see his topography, totally normal on the right eye, but left eye has definitely got some keratoconus or steepening on that left eye. Sees 2200 with a refraction for glasses, he can get down to 2060. And first I trialed a scleral lens and the insertion was so difficult. He was just one of those people that squeezed their eyelids and he was so scared. But when finally got it in, he was able to see 20/25 and he was so excited because he hadn't seen that well in years. He had very, very, very difficult time with insertion and removal, but he really, really wanted to try it. So we worked with him. We spent many hours with him. My technicians did just such an amazing job, spending a lot of time with him and his mom and just working on getting this lens in. At the follow-up, he still was just not able to insert that contact lens no matter how much we worked with him. And he was just really, really scared to insert and remove the lens. He just had lots of apprehension for that lens. So then we discussed a soft lens, and he said, yeah, let's try that. So I fit him with the Flex Lens Arc. We did the diagnostic fitting, ordered the lens, and he sees 20/40. So remember, he sees 2200 without anything. He sees 20/60 with glasses, and he saw 20/25 with the scleral lens. So the vision is not perfect, and it's not as good as it could be. But, for him, somebody that was just so apprehensive and just could not get the lens in, this just ended up being a fantastic option for him. So scleral lenses, they do work well for many patients, but there are always going to be some patients that will do better with the soft lens. So basically, contacts can be available for everyone depending on what their needs are and the practitioner goals as well. So I'm just going to skip through this and just some last minute pearls. Custom soft lenses are an awesome option. It's really helped me maintain a lot of contact lens patients that would have dropped out of lenses. It's great for normal corneas and irregular corneas. And why not give our patients the best lens possible, something that is truly custom to them?
Okay, Stephanie, very good. I don't see anything coming up, and I think with respect to your time and schedule, as well as everybody else's, we'll bring tonight's program to an end. And I want to thank everybody for taking time out of your busy schedule to attend. And I really want to especially thank Dr. Stephanie Wu for an outstanding presentation pertaining to a topic that we all want to know more about to help minimize, if not eliminate, scarring and improve the quality of our patients. And I'm particularly appreciative that all of you have that interest, and this might be our most well-attended webinar of the year. But please come back, join us Tuesday night, August 15th, when the topic will be how to optimize contact lens comfort, and the presenters will be Doctors Mila Bruchek and Dave Kading. Good night, everyone. We'll see you next month.